I'll be starting with this case of a 10 years old girl who had a femoral neck fracture on the right side, sorry, there, and were treated with close reduction and internal fixation with K wires. And this procedure was done elsewhere, not in my institute. So, unfortunately, the patient developed avascular necrosis and resorption of the head and neck. And this is how the girl presented to us. So, patient had Trendenberg gait and was worried about the limb. So, what we did was uh, Ilizarov hip reconstruction procedure using the limb reconstruction or monolateral fixator. And this is what we did. And this is after about 6 weeks, and then the thing were consolidating. And we removed the fixator after consolidation, but this patient had at the distal site a femoral shaft fracture, which was treated by close reduction and elastic nailing there, if you see. And this is a follow-up at 1 year. You can see that the function is full. She's able to squat. She's able to, there's no problem with the standing. Her limb length discrepancy is not there. And she's able to sit cross-legged. And that's her gait. And if you don't see the scars there on her right side, you can hardly notice the limb. This is another patient with a resorption of the neck following osteomyelitis. And we did the same procedure, lengthening and varus downstairs in the distal femur. And that's same at the end of the procedure. That's the function. And that's the gait. And you can hardly make out which side is involved. So, understanding the pelvic support osteotomy, if you see the normal mechanics, what happens is if the patient puts this foot on the ground and lift this side of the pelvis, the abductor muscles here, they will contract and lift this. And this is the normal gait. However, if there is a abductor insufficiency or there is a break in the lever arm, what happens is that this limb tries to go into adduction, adduction. And if the person stands on the affected side, then what happens is a dipping down of the pelvis. And this is what leads to a Trendenberg gait or a lurch. Now, what is important here is that a free adduction is must for a abductor lurch. And if there is no free adduction, there is no abductor lurch. So this is the basis of the proximal femoral osteotomy, that it provides a stable fulcrum for pelvic support by increasing the abductor lever arm as well as eliminating the free adduction possible. So there are some variations of pelvic support osteotomy. It was described first by Milch in 1941, where it was subtrochanteric with less valgus, Shan's in 1951. Elizarov modified the above with a additional lengthening and vericization in the distal part of the femur to correct the mechanical axis. And if you don't do that, there is a lateral axis deviation at the knee, leading to a lateral compartment osteoarthritis in later stage. And in conventional PSO, the shortening is also not addressed. In Elizarov hip reconstruction, there is extreme valgus extension and a bit of internal rotation. The lengthening and axis correction is done distally by a lengthening and varus osteotomy. And if there is a fixed flexion deformity, you add extension at the proximal osteotomy site. So how do you plan this? These are the figures which we are well versed of by, this is from the Draw-Pelle's book. So what you do is you go in for maximum adduction at the hip and do a osteotomy at the level of the ischial tuberosity. And then you straighten the limb and it will end up in a valgus at the knee. And then you do a second osteotomy in the distal femur to sort of realign the distal femur, the knee joint, the knee joint. So the second osteotomy is passing through the apex of the first osteotomy, and the distal axis line is mechanical axis line of tibia extended proximally. So wherever they meet, that is the region of Wiroc, and usually it is in the mid femur or in the distal femur. So this is one such patient where there is a proximal valgus, distal lengthening and vericization. So this is what you do. You can do it with Elizarov also. You can do it with a plate combined with a fixator as well. And you can do a isolated subtrochanteric valgus, but then you end up in a valgus at the knee. So one has to achieve about 15 degrees more abduction of the distal fragment than the maximum possible adduction at the hip. So let's say this adduction is 70 degrees. Sorry. So you abduct the fragment 70 plus 15. So that would be around 90 degrees. So usually adduction is around 50 degrees or so. So you have to abduct 50 plus 15. So that will amount to around 65 degrees. If you do it with a LRS, you have an extreme angle there, extreme angle. So this leads to slipping of the pins and the drill bit. So we devised a little tip that you place the osteotome there at the end of the drill bit. And then this will prevent the slipping of the drill bit here. Then you can safely pass the pin if you are using a monolateral fixator. So in conclusion, pelvic support osteotomy is based on taking away free adduction along with abductor tensioning. Limb axis of valgus resulting from proximal femur abduction osteotomy is corrected by a femoral osteotomy at a distal level, usually in the middle or distal third. And distal femoral osteotomy also allows lengthening and limb length equalization. Thank you so much.